Maybe that's why I've held on to my Bitcoin. Lack of testosterone. What is a normal state for a man? Should they be having a morning erection every day?
Sex has gone from being something they do for fun to something that's become regimented.
Let's just return to sex for a minute. I think there's a misconception that we can just have sex whenever we want.
Because we know if their stress is not managed properly, their testosterone levels will be negatively impacted. I can't see a way that making your bones stronger isn't worth a shot.
Welcome back to episode 5 of The Best of Both Worlds, the ultimate in healthcare conversations where we look to discuss, consider, and potentially even find the humour in our quest as healthcare practitioners to optimise performance. That is sports performance, psychological performance, emotional performance, and just performance in life in general. We hope to learn with you, to share with you, and to create powerful, high-performance lives. I'm Matt Winter, Doctor of Physical Therapy with training in functional medicine, and I am here with Paul McCauley, Senior Podiatrist, otherwise known on TikTok as the legendary Paul the Podiatrist. How's it going, Paul?
Very well, very well. Really looking forward to today. I feel like I can add a lot to this episode today. So we've got another special guest today. We have Dr. Neil Forrest. He's a British medical doctor who's been practicing in Singapore for almost 10 years. He's a board certified in lifestyle medicine physician and has special interest in preventative medicine and health span. He also has a degree in sports medicine and plays regular football, tennis and golf. Dr. Neil is based at Osler Health in the Holland, Buena Vista area. So now, first of all, welcome, Neil.
Hi guys, thanks for having me.
Very excited for today. We have a tradition which is now 5 episodes old, but a tradition nonetheless. How are you out of 10?
How am I out of 10 today?
Yes.
8.
Yeah, and why?
Solid 8.
Why 8?
Well, I've just come from a busy morning clinic, so that's probably shaved me down from a 10. Seeing lots of patients with influenza at the moment, so I've had sort of mask on, mask off all morning. But no, feeling pretty good.
That's great. Matt, how are you feeling out of 10?
Yeah, I'm feeling pretty bright actually. I think I'm an 8 out of 10. I was a bit lower earlier on because we had a discussion, didn't we? Podcast is going well, but it's tough, isn't it? There's a lot of work to do. Brought me down a bit, but it also then brought me up again because we resolved stuff. We had a nice little moment, didn't we?
We
had a cheeky hug.
Yeah, we had a hug. So yeah.
So 8 out of 10.
That's great, Matt.
And sorry, it's all about me, isn't it?
No,
it's all about me. It's classic. How are you, mate?
I am I'm probably like 5, maybe 5 out of 10. I don't know, maybe slightly. It's on the up, but I was emotional earlier today, and I've been like tired, stressed, and work's been, like I've said every week, work's been really hard. And then just like the podcast's been quite intense, just getting everything edited. We did have a moment. We did resolve everything, which is good, but still, it's picking up. And hopefully by the end of this, it'll be.
Well, should we check back in at the end of the podcast and see how you're getting on?
Yeah. Let's try that. Yeah. See if we remember.
Brilliant. Okay. See if I remember to ask you how you are.
Yeah. Exactly.
Yeah,
exactly.
All right. Let's rock on.
So today we're going to be talking about testosterone. Testosterone is big for me because I actually have been taking testosterone supplements since I was young, since I was 14 years old, and I feel like I've got a lot to share today. So hopefully I can get a word in past Matt, which is usually quite tough. But yeah, I'm looking forward to it. So, Dr. Neil, what is testosterone?
Okay, so in the simplest terms, testosterone, it's a hormone. Hormones are signaling molecules that the body uses to tell other bits of the body to do something. It's a steroid sex hormone, so steroid just refers to its chemical structure. So you have the sex hormones, testosterone, estrogen, progesterone. I know you've talked about some of these others in the previous episodes, are so named because they perform sexual functions, but that's not all that testosterone does, as we'll come on to. Its original building block is cholesterol, like a number of other hormones, but it goes through certain phases to get there. And what more do you want to know? Where is it produced, I guess? It's produced in men, mainly in the testes. There's some production in the adrenal glands as well, and some production in the ovaries in women. But for the sake of keeping it simple, let's think about the testes for now. And it binds to a receptor on cells called the androgen receptor, when it binds to that receptor, it then transmits a chemical signal to tell that cell to perform certain functions, which I'm sure we're going to come on to. So that's what testosterone is, and we'll talk a bit more about what it does, but it's essentially a chemical in the body that we manufacture. So we don't need to ingest testosterone in our diet to make it. It's something that we build from basic chemical building blocks and cholesterol.
Fantastic. And there's a lot of talk out there that testosterone decreases over your lifespan. Is that like inevitable, or for some people does it not happen, or does it happen for all men?
Yeah, so as you can imagine, it's very variable. Levels in men on average are about 10 times what you see in women. So that's the first thing to understand, is that you're going to see wildly different levels between the sexes if you check them. And then in different phases of life, you have different levels. So you actually see very high levels in newborn boys and girls. Then that falls very, very quickly, and most children will have low levels of testosterone, unless there's some genetic reason for or endocrine disorder going on for them not to. Then I think probably the stage of life that certainly most of the men listening to this will recognize is in adolescence, where production starts to ramp up again, particularly in boys, and causes a whole bunch of adolescent physical traits and behavioural traits that we might recognise in our younger selves. And then, in men, what you will generally see through life is a gradual decline over time. And we'll talk maybe a bit more about what accelerates or decelerates that decline. But I would say it's fairly typical for you to have less testosterone in your system at 60 than you did when you were 20, for the typical man, all other things being equal, although clearly that can be modified both medically and through lifestyle, but that's the general trait. I think what I read online and in social media, and a phrase I hear is andropause, or male menopause, and I think it can be a useful term to help people conceptualize it, but I think it's also problematic if we're equating it to the menopause.
And does it also almost imply an inevitable change in male hormones? And that's a problem, right? Because there's certainly reports that some men are able to maintain testosterone levels through their lifespan.
Yes.
And therefore, andropause isn't necessarily inevitable, and therefore why are we giving it a term? Is that...
Yes, in the way that, let's say, menopause is.
Yes. Yes.
Menopause varies in its severity, its age of onset, but you can say to a woman, at some point menopause is going to happen. It is guaranteed. If you live long enough, you'll go through menopause. Whereas in men, it's a far vaguer process. Some men, there are studies that have checked testosterone levels in much older men. Some men seem to barely experience anything. And even in the more severe cases, it's a gradual process. Whereas what happens on the female side with menopause is that estrogen production falls off a sort of cliff edge. You do go through a perimenopausal period, but there's a point when your periods stop, and it seems to be that very rapid withdrawal of estrogen that then gives rise to a lot of the symptoms of menopause. You don't generally see that in men. In certain medical situations where you give a hormone blocker, prostate cancer for example, you may actually see men having flushes, vasomotor symptoms, very severe sudden onset symptoms because you've suddenly switched everything off. But outside of those situations, I think it's far vaguer, and that's why I think it can be an unhelpful term, because I think there's been such this huge battle for so many years for women to have recognition of menopause and what it means and to talk about it. And I know you've had my colleague Tash on recently to talk about that. And so I don't want it to be another thing that men steal and say, oh yeah, we have that as well. It's not the same thing.
Yeah.
It can still be very distressing, debilitating, and we should take it seriously in men, but it's not quite the same.
Yeah, there's potentially more modifiable risk factors, right?
Yeah.
We'll come on to that, I guess.
So if we talk about physical and mental effects of testosterone, like I know when I was young, I especially when I was 16, 17, and all my friends were going to the gym and I would go to the gym, I just felt like I couldn't lift as much as they could, and actually I'm still relatively weak.
But you just look at a weight and your biceps grow.
Yeah.
So I don't know what's going on.
I
wish I had that problem.
It's unbelievable.
Matt is definitely jealous. So with regards to testosterone, like how does it affect us physically with like muscle mass, strength, and like our overall performance?
Yeah, so the way I like to speak to patients about it when they ask me that is to sort of divide the effects up a little bit. So there are the androgenic effects, as they're known. So those we're talking about sort of male sexual characteristics here. So male development in adolescent boys, the obvious things, hair growth on the face, hair growth downstairs, the sexual functions that testosterone gives, sperm production, helps with erections, and the development of all those male characteristics. So that's one function. Then it has its sort of anabolic function, so what you alluded to there in terms of muscle mass, performance, strength, even endurance plays a role in that as well. And this is one of the reasons why we have separate male and female events in sports. It's because a big part of that is testosterone and the effect it exerts is one of the reasons why testosterone is, and synthetic steroids are drugs of abuse in terms of performance enhancing. So it has these anabolic effects, and then it has behavioral effects as well. So we were talking a little bit about this before we came on. So certain behaviors that may be sort of stereotypically classed as male behaviors, but we know that testosterone is playing a role in that. Aggression, risk-taking, impulsivity, libido, I guess. So that sort of bridges the divide between a sexual behavior and a sort of psychological behavior.
And that can be libido in women as well, right?
Yeah, absolutely. And for all of this, I'm talking about in women and men. So it's
Right.
important. Although men's levels are 10 times that of women, women do have testosterone in their body, and it has the same effects. So it will enhance strength, performance, it will affect libido, it will even cause some of those male characteristics in excess, like excess hair growth, skin changes, that kind of thing.
Is it the higher the testosterone, the higher the libido?
Not necessarily. As with so many things in the endocrine system, it's true up until a point.
Yeah.
So if you take if you take someone who's testosterone deficient and correct that, you'll probably improve their libido.
Yeah.
And then even within, I would say, healthy ranges, you take a guy in the lowest quartile of the range and bump him up to the upper quartile.
Yeah.
Most likely he's going to report a change in that. But I'll probably come on to later why the absolute cholesterol number isn't the whole story.
Yeah.
If we can just rewind a little bit, and we mentioned aggression then, and we had this discussion just before we came on as well, which was there's been a lot of talk about testosterone and aggression, and it seems to get a bad reputation in a sense because of that. And I think a lot of the studies, and correct me if I'm wrong, were associative studies. So you look at an aggressive population, perhaps a population that are found in jails, for example, and they will tend to, or the more aggressive inmates will have higher testosterone levels. But also testosterone in a population group that doesn't have a tendency towards aggression. We're talking about physical aggression. That's the assumption that we make when we hear the term aggression. Might not then display physical traits of aggression related to that. So they might be asserting dominance in another way. They might assert their dominance, maybe particularly, we see it quite a lot here, in financial ways, showing their flash cars and things like that, but essentially trying to establish themselves on a social hierarchy. And I think the hypothesis that was come up with was the challenge hypothesis of testosterone. So it's about how we establish ourselves in a social hierarchy. So when you say aggression, is that not necessarily physical aggression?
Yeah, absolutely. So it can be in a more extreme case, but no, more aggressive behavioral traits. I mean, this probably serves an evolutionary purpose, right? So if you look at our closest relatives in the animal world, a lot of primate societies are built around a dominant male and males displaying aggression towards each other as a way to win mates and that kind of thing. So both the physical characteristics that having higher levels of testosterone gives you, bigger muscles, bigger physique, more hair, are sort of displays of that potential for aggression. But I think in the human world that clearly manifests itself in different ways. It can be in men fighting with each other, and you probably do see that more in the male parts of society than the female, but it might be in the workplace. It might be in their attitude to risk or certain behaviours. So you look at, you compare performance of retail investors, male versus female. Women on average do better than men because they make less impulsive decisions. They stay in the market for longer. That kind of, so
maybe that's why I've held on to my Bitcoin. Lack of testosterone.
So whereas, from an evolutionary perspective, some of these traits might have been quite rewarding. Take a chance, take a big risk, show aggression. In the modern world, it's probably not always the optimal way to behave. But I don't think we can just blame our testosterone. You come to see me and we decide that you would benefit from testosterone treatment. I give you some, and then you go outside and beat someone up in the street. I don't think the defense cannot be, it was the testosterone.
Yeah.
We're still masters of our own destiny. We're still able to control our own thoughts and behaviors.
Yeah.
But it is something to be mindful of, when we're talking to someone about elevating the testosterone levels, whether that's artificially or naturally. You've got to take the rough with the smooth. There will be, we hope, more benefits than downsides, but that's that needs to be individualized.
I think Matt does, because Matt obviously does talk to me about my hormones and stuff. Like, we'll just chat about it. He can tell when, like, maybe I've had my injection.
Right.
After about a week, maybe I'm suddenly a bit more pumped up, in conversations with maybe colleagues, that I get a bit red-faced and a bit like into it, aren't I?
Do you notice yourself?
Yeah. And then when I come towards the end of the sort of 10-week cycle, I feel like I'm not keen for conflict. I just I'm in a shell more.
I think it adds to your motivation. I noticed that. But I think it just turns up, as we said before, it almost turns up the dial on your other character traits or your behavioural traits. So you're still Paul.
Yeah.
You're just Paul times 2.
Yeah, exactly. Yeah.
That's what I noticed.
Yeah, it's quite interesting.
And I think, like any of these sort of subtle behavioural effects, you've got to, there's an element of try it and see, because it's hard to know how someone is going to react to that. Some patients say to me, it's just great. I just feel more motivated to get out of bed in the morning and do stuff.
Yeah.
And certainly, one of the things that's been looked at in testosterone when we try and appraise its effects is overall well-being scores. And that can be quite hard for people to put into words. It might not be that their libido's increased or that they can lift heavier weights this week in the gym. It might just be a general sense that they can't quite put into words of, I just feel better. And that's really important as well. But you might not feel that. You might already be motivated enough, and actually this stuff is tipping you over into feeling anxious and agitated all the time. And so it is a balancing act. And this is why it's so important to listen to what people are telling you about how they feel, rather than get too bogged down in numbers we absolutely need to know your levels.
Yeah.
But we really, a lot of the time, we're treating to symptoms and feelings rather than absolute levels.
Brilliant. I think that brings me on to my next question, really, which is when I'm trying to listen to a patient's story, and I mentioned last time that we often do see people in their 40s, 50s, 60s for many reasons. If you dive down into how else they're doing in their life, they'll often mention things like they're less motivated. There's potentially a little bit more apathy at work. They don't necessarily want to get out of bed in the same way that they did before. So I certainly ask about apathy when I'm thinking about, is testosterone a player with my male population particularly? Is that something that you discuss with patients? And are there other signs or symptoms aside from libido, which is quite the obvious one, that you talk about with patients?
Yeah, so the advantage of talking about more clear-cut symptoms, so libido would be one, erections, particularly morning erections, whether they're still present or not, can be much more reliable indicators that it may be a testosterone problem. The issue with symptoms like fatigue and apathy is they're so multifactorial. So one thing as GPs we see all the time is people who are tired, and the list of possible causes for tiredness is never ending in a medical textbook. And that's just the medical reasons. Actually, most people don't have a medical issue. Most people are tired because their life is tiring. So those are really important. And again, this is where there are other similarities to menopause care, in that, other symptoms like brain fog and memory impairment, focus, muscle and joint symptoms, are often overlooked, because a lot of guys will naturally equate sexual function with testosterone levels. Whereas they might not do for these other things. So it's important to ask. But often we don't know for sure whether testosterone is a factor until we correct the problem and see if those symptoms improve. So really important. And I think if you're feeling that way and you're not sure why, it's really easy to get your testosterone levels checked.
So we'll come back to testing later. Let's go back to those symptoms, because I think it's great for people to be able to flag up on themselves that they might have a potential testosterone issue, but also for clinicians as well, who are listening, to know what questions can I be asking. So we spoke about libido. You just mentioned morning erections. What is a normal state for a man? Should they be having a morning erection every day? Should it be a couple of times a week in your 30s and 40s? As obviously it's not like when you were 15, 16, or is it?
Yeah, it's probably too variable to give people clear-cut guidelines on that. I think it's certainly not normal for it to be every day, so that's fine. People listening to this don't need to be panicking if that's not the case. Yeah, but I think what some guys describe as is that they really notice a drop-off in frequency, or they're non-existent. And so, I think comparing yourself to your sort of 15, 6-year-old self is who wants to do that? But maybe, probably a more typical thing I would see would be a guy that maybe through his 30s, noticed that he had morning erections pretty regularly through his 30s, on half of days, let's say, and now he barely noticed them at all. Yeah. And that's normally part of a bigger picture in terms of reduced libido overall, so reduced desire. It's difficult to tease out sometimes, what's libido and what's erections, because another symptom of lower testosterone is not just reduced morning erections. It's maybe impaired ability to get or sustain an erection, and there's a real chicken and egg thing there, because there's for a lot of younger guys, they're not going to have a huge vascular problem causing their erectile dysfunction, and so there will be a big psychological part to it. And it's sort of, have I got lower libido because I can't get an erection as well as I want, or is the inability to get an erection making me so scared of having sex that my libido's just gone out the window? Which one came first? And so, and with the ready availability of ED medications, like Viagra and Cialis, you may see a guy who's taking care of the erection side of things comfortably with medication, but actually all the other testosterone symptoms are still there.
So it's almost covering it up and leading to him to neglect the other health issues that are going on. So it's really important to investigate a bit more before a man then embarks on this journey of Viagra potentially.
Yeah.
Even though it might be a good short-term fix, and maybe even breaks the cycle, the psychological component.
Yeah, absolutely. The medications have huge value, and the great thing about them is they tend to work whatever your underlying cause is. So that's good. We have a sort of a ready-made solution for a lot of guys who are going through that, and that's incredibly helpful. But you have to sort of think, well, what is the underlying cause? Is it just psychological? I see that a lot. Great example would be someone who's trying to start a family. Sex has gone from being something they do for fun to something that's become regimented and they're against the clock, and suddenly they can't get an erection anymore. So probably not a testosterone problem, probably not a blood flow problem, versus a 70-year-old guy who's smoked 30 a day his whole life, is overweight, drinks too much. He's probably got a combined test. So the patient demographic, the patient's other lifestyle factors are going to give you a lot of clues as to what's going on there.
That's brilliant.
I was going to add in, just like, so some things which I notice are like brain fog when I'm low on testosterone, and I'm maybe a bit more sensitive. I can get upset easily. are those things that you would also see in like these other men?
Yeah, absolutely. So, I think what you tend to see is, I think, on the lower side of the ledger, so people with testosterone deficiency, depression and anxiety are common symptoms. Out and out clinical depression, not just sort of feeling a bit down in the dumps every once in a while. So it can be that extreme. On the high side, so let's say you've got a bodybuilder that's abusing testosterone and is way over the reference range. You can still see mental health issues there, but it tends to be more on the sort of agitated anxiety side of things. I see it's not so much the sort of feeling very demotivated and depressed. It's sort of feeling very on edge and very snappy. So I think that knowing what those symptoms of the extremes of high and low are gives us a bit of a window into understanding where we might be on this sort of more normal range spectrum.
Let's just return to sex for a minute. I think there's a misconception that women definitely need the time to be right to have sex. Potentially the environment lights some candles. They need to be in a good place mentally. But for men, we can just have sex whenever we want. And I don't think that's true. I believe there are psychological components to sex. Potentially testosterone is linked to that. And there potentially is a dopamine involvement as well. Is that something you discuss with patients, and is that something you're in agreement with?
Yeah, so I think, when we're talking about either someone who's struggling with their libido or someone who's experienced erectile dysfunction, we have to talk about the whole package. And it has to be a very spontaneous thing. I don't mean the sex has to be spontaneous, but the process has to be very spontaneous. Once you start worrying about or analysing the mechanics of the process, it just doesn't work. And so this is why, you mentioned dopamine, but this is why any sort of form of psychological stressor is going to impair libido and erections in a man, because if you're thinking about your mortgage payments or the big meeting or presentation you got to do tomorrow, then it's very unlikely that you're going to have a satisfactory erection in that situation. Equally, if what you're worried about is the fact, can I or can't I get an erection, then that becomes self-fulfilling. What I mean? We've kind of strayed off testosterone into erectile function here, but I guess it is, it's important to bring up because it's all bound up in this sort of sexual health element of it.
Yeah, definitely. And we talked about stress with Dr. Tash in the previous episode, and the effects that stress can have on estrogen. And we spoke about it in the context of pregnenolone steal. So under times where you're under persistent stress, your body, as you say, preferentially creates cortisol from that cholesterol pathway, instead of going through that DHEA into estrogen pathway. I would imagine the same thing happens with testosterone, and that's potentially another reason, if we're linking it back to the erection issue, why, if testosterone is the main player, maybe stress is at the root of that.
Yeah, so I think, if we're going to sort of go into the potential causes of low testosterone, we've talked about low or diminished testosterone in the context of gradual age-related decline, but there are other things that will cause low testosterone at any age, and stress is definitely one of them. I guess maybe this is the bit where I'm going to disagree with you slightly on
go ahead.
So I'm not sure I buy the pregnenolone steal theory, but when someone, if a patient asks me about it, it kind of doesn't matter. So I don't think that we've got this amorphous pool of pregnenolone floating around our body that different endocrine glands will take and manufacture hormones and secrete. You know what I mean? Because you could take it one step further back and talk about cholesterol steal, couldn't you? And so I'm not convinced I've ever read anything that that's the problem when we talk about stress, but it's not up for debate that stress is going to impact testosterone production.
Okay, so let's put it another way. So if we think that there's no stealing going on, but is there an issue with cortisol and suppression?
Correct. Yeah.
So we see that in, say, endurance athletes, for example. So high levels of cortisol after persistent endurance races or training, and then potentially reduce testosterone. So is there a link at all between high cortisol and suppression of testosterone, or lower testosterone, should we say?
Yes.
Let's put it that
absolutely,
way.
Absolutely. And who knows, is that mechanism exerted through the fact that cortisol is high? Does that have some down-regulation effect on the hypothalamus or the pituitary gland or the testes or the adrenals? Or is it the stress, and cortisol happens to be there as a marker of stress? I say, I don't think for most people who are trying to work it out for themselves, it doesn't really matter, because we know if their stress is not managed properly, their testosterone levels will be negatively impacted. We don't want that to happen. And so managing stress and dealing with it becomes imperative, regardless of chemically how that mechanism is being exerted.
Is it associative or causative? You still have to manage.
Exactly.
Okay, great.
And again, if we think about it, going back to sort of trying to come up with a plausible evolutionary theory as to why that may happen, is when the body's dealing with stressors, whether they're psychological or physical, is it prioritizing procreation and attracting a mate and all that kind of thing? If we bring it back to its very basic levels, it would make sense, right, that testosterone production wasn't prioritized in a high stress environment.
And that's why with the overtraining syndromes in women, you get the lack of periods, and in men, you're getting this low
It's an
testosterone,
adaptation.
and it's an adaptation.
Yeah, it's the
Makes
body
sense.
doing what it's supposed to do. It's just an undesirable effect that we know we want to avoid for long-term health.
Great. So let's move away from sort of performance for a little bit and sex, and let's talk about pain. Obviously, that's something that Paul and I see a lot in our clinic. We certainly discussed with Tash previously on estrogen that we see women with lower levels of estrogen potentially exhibiting more pain type symptoms. In men, is that the same? So as testosterone reduces, do we see elevations in reported pain?
So yes, we do. And I'm not sure we've got the level of evidence that we do for estrogen, because HRT as a phenomenon is just more widely used and more studied than testosterone replacement therapy. And we know that improves pain scores, that a lot of women who complain of joint pains see those improve when they manage their estrogen levels. And so it's completely plausible that the same thing happens to testosterone, and certainly anecdotally I see that. In terms of mechanisms, well, it has a massive effect on muscle. It has a massive effect on bone density. So one of the outcomes of low testosterone that we haven't talked about is osteoporosis. So why would it not affect musculoskeletal pains and aches? And it just makes perfect sense to me.
Yeah, it seems very multifactorial then. So maybe we can touch on those in a second. It also seems that potentially testosterone or low testosterone may be linked with higher levels of inflammatory cytokines like IL-6 and tumor necrosis factor and things like that. So again, I think we don't know whether that's associative or causative again. So it might be in these people, they're generally inflamed, potentially overweight, obese, and therefore they have lower levels of testosterone and higher levels of inflammatory cytokines. So I think there have been some studies showing administration of testosterone reduces pain, but then I also saw some research showing that if you give a single dose of testosterone, that the expectation of pain can actually go up, and the experience of it, and potentially linked to this higher acuity or this expectation of focus around the body. So I think, as you said, it's very mixed.
Yeah, it's an interesting one, isn't it? I mean, I think for someone who is experiencing some sort of musculoskeletal pain and we're thinking about testosterone, I can't see a way that making your bones stronger and making your muscles stronger and perform better isn't worth a shot. Not saying that it's going to help everyone, and I wouldn't use it. I think when we talk about giving people hormones, I'm not talking about naturally boosting here, which I think is that's anyone can do that if they really want to. But if we're talking about giving someone testosterone treatment, there are things that we know may improve, but on their own wouldn't be an indication for doing so. Improvement in bone density That's a given. But is osteoporosis a licensed use for testosterone replacement therapy? Not in many countries where I've worked, but so there's these very clear-cut benefits, and then there's these sort of almost fringe additional benefits that we know you might get. Would I jump in with one of your patients, if you sent them to me with pain and say, right, we're going to fix this with testosterone? Probably not, but it may be part of a bigger picture.
But if they were not having morning erections, their libido was down,
Exactly.
and they happen to be in chronic pain, if you think, maybe as a bonus, you might actually get some pain relief here.
Exactly.
Yeah, fantastic. And in terms of bone density, I believe it's the aromatization of testosterone to estrogen that maintains that. Is that right, or does testosterone itself have a direct effect on bone density?
That's a good question. I don't know whether it has a direct effect or not, but yes. So what we haven't talked about yet is what happens to testosterone in terms of its end product. Does it stay as testosterone, or what happens to it in terms of its end products? And one of the end products is estrogen, even in men, and we need some, and it's a good thing. The thing I would say about hormones and bone density, whether you're giving someone estrogen directly or testosterone, is they don't magic up bone density by themselves. That the stimulus is still required.
But if you've got higher testosterone and you can grow more muscle, then you're going to have more torsion on the bone.
Correct.
You're
You're
potentially going to
but
load more.
what I mean is, what we shouldn't make people
it doesn't
believe
magically
is
grow bone.
Yeah, you still have to earn the bone density.
Ironically, it does magically grow bone as well.
Yeah, very good.
I had to get that one in. I had to get one
but
in.
Yeah,
so,
you've got to put the work in. You can't just get the hormonal balance and then in the same muscle being the classic example of that, right? These sort of bodybuilders through the 70s and 80s weren't just injecting steroids, or even now they're not just injecting steroids and getting huge muscles the next day. The steroids are allowing them to train more, to recover more quickly, to achieve maybe higher levels of intensity in the gym. And then that's what's leading on to the muscle growth. So it's the same with bone density. You have to do the activity that triggers the body to say, okay, I'm going to lay down more bone here.
And is that just weight training?
No, not necessarily, although that seems to be optimal. So it's the torsional stress on the bone. Any sort of load-bearing exercise will have some effect. So even running in the lower limbs, at least, and in the lower spine, will have some benefit. But resistance training seems to be king in that regard.
From what I've seen in that realm, and the advice I give my patients is that you're trying to get a bit of everything. I would say strength training is that torsional stress, that pull on the bones, which signals for that bone density. Then you've got that loading, which is what Neil was talking about, the axial load. But then even things like changing direction, because it puts a different force on the bones, like tennis, for example, you guys and Tash. So you'll all be safe. That changing direction seems to have another great effect. But the other amazing thing about bone density is, as you alluded to there, it's specific to the bones you're loading. So running doesn't improve as much your spinal as it might do your hip, for example.
Correct.
So I say to my patients, you have to load the spine. If you want to improve the density of your spine, you have to do back extensions or whatever it is. Anyway, we segue a little bit.
Yeah. But what do we see in a lot of, older osteoporotic patients? Of course, we see spinal collapse and we see hip fractures, which have devastating impacts. But we see wrist fractures and humerus fractures all the time in elderly people. And so, there are fewer sporting activities that would maintain bone density in the upper body, right? I think that's kind of one where you've got to do the resistance training.
We could just look at Rafa Nadal's arms, couldn't you?
Yeah, well, there's only one of his arms.
Only one, yeah.
To the left arm.
So that's a lot of people who run, who cycle, who it's very lower body focused in that regard. And so I think picking up some heavy stuff or getting some resistance bands or whatever it is, even doing some push-ups, that you need that upper body bone density as well. When we scan people's bone density, we tend to focus. So as a standard bone density scan is hip, spine, and neck of femur, and that's great because those are the ones that carry the highest morbidity with them. But we shouldn't neglect the other parts of the body as well.
Thank you so much to Dr. Neil Forrest. What an interesting start to our series on testosterone. Join us in part 2 to dive a little deeper, but until then, sleep well, keep strength training, and manage that stress to keep that testosterone high. Take care.